the first button. Play from start. Yep, I think, yeah.
There?
Yes, great.
All right, all right.
No,
Okay.
Today we had many technical difficulties.
That
Okay, great. So we're eager to hear.
perfect, perfect. So before I start, I want to thank Raul for his invitation and Zoya for her amazing technical help. We were on these since an hour ago. I was trying to get on, and I was curious actually to hear Ilya's presentation because that might have some overlap, but nonetheless, I'll just, I'm gonna keep on talking about the novel pharmacotherapies in Parkinson. I don't think we can get to L-DOPA-induced dyskinesia, but I promise I can show you one slide at least. And before I start, so I was in St. Petersburg 3 years ago. Yeah, for the World Cup, I visited Raul and the lab, and it was really nice. And I hope we can get together somehow again. Now,
certainly, next year we are inviting you first in person.
Perfect, perfect. Perfect. Looking forward to it. So now I want to give you a little bit of history where I am and exactly our location. So Howard University is the first HBCU, which means historically Black college or university. Some people, when they hear Howard, they think it's Harvard, but there are two very different schools. Harvard is in Boston. Howard is in Washington, D.C. And it is the first HBCU that was established right after the Civil War. As you see, it's more than 150 years old. And the reason it was established was that Howard, Oliver Howard, was a general in Lincoln's army. And when the Union won, Howard, General Howard, to give an appreciation to the Black soldiers that had fought with him, petitioned the government to start a center of higher education for them. And so that's how Howard got started. And it is now one of the, so it was the first Black university, and now there are more than hundreds of them. And it is considered the Harvard of HBCUs because it was the first one. I have put my email here for anyone that can, that would like to contact me later. But we are located in, let's see how am I advancing these. Okay, in Washington, D.C., a nice area of Washington. This is a reservoir. We're about only a few kilometers from the Capitol and the White House. So we are strategically located. It is, although it gets some funding from federal government, it is considered a private university, and predominantly Black students attend this university. And it is, in terms of tuition, less than other private universities, definitely. This is a new science building, and I'll show you where exactly I am. I'm in this building on the 3rd floor. And as you see, most of the graduates are minority students, but we get students from other African countries, Caribbeans, as well as all the states, basically, and about 20%, I would say, are non-Black. So it takes pride in producing the highest number of Black doctors in the nation. And this is, I'm on top of this building, the third floor, and this is the view of from my window. And this is the library I was showing you. So this is basically where I am. So for those of you that might visit me, you know where, what to expect now, kind of. So, and I hope to see some of you here. Let me now go to Parkinson's. I don't know if Ilya showed any of these things, but just as a review, this is a progressive neurological disease associated with aging, usually over 60. And you know some of the cardinal symptoms: shaking in the hands, the rigidity, the stooped posture, and difficulty in walking, and so on. There are both motor and non-motor symptoms with PD. So the main motor symptoms is akinesia, means loss or impairment of voluntary movement. Then, as I mentioned, you have rigidity, resting tremor, and postural instability. So these people cannot maintain their posture and they might fall, and fall is the biggest risk and problem with further disability. In addition to these motor symptoms, the non-motor symptoms can also be rather devastating. So you have emotional changes. Depression is very common in this situation. Apathy or lack of interest, anxiety, cognitive deficits, memory impairment. You have sleep disturbance, either lack of sleep or too much of sleep, autonomic dysfunction. They have bladder disturbance, orthostatic hypotension, sweating, sensory symptoms. You can have pain and olfactory deficits. Usually the sense of smell seems to be affected, just like in COVID in a way. GI symptoms, you can have constipation, nausea, and they have kind of a masked facial expression in that one would think that they are non-responsive, not interested, but it's really that they cannot express, and so people might think that they are not interested and so on. So there is this lack of recognition of verbal or nonverbal cues. As you might know, or some might not, the problem with this neurological disorder is that you get degeneration of the neurons in substantia nigra. This is a very important dopaminergic system that projects to the striatum. And because of the lack of dopamine transport to the striatum, you get all those symptoms. But the nigrostriatal pathway is one of the 4 main dopaminergic pathways. So you have, in addition to nigrostriatal that we just mentioned, you have mesocortical that starts in ventral tegmental area and goes to nucleus accumbens. This mesolimbic, the mesolimbic is very important in reward system, and basically all drugs of abuse, all addictive drugs affect this pathway, mesolimbic. And then you have the mesocortical that goes to the cortex that has something to do with motivation mainly. And finally, you have the tuberoinfundibular that starts in the hypothalamus and goes to the pituitary. And this is very important in endocrine function, particularly prolactin release and so on. So this is just to show you that there are all these dopaminergic system. And so when you affect one system, it is possible that you are affecting others as well. Now, as far as dopamine synthesis is concerned, you might have seen this already, that you start with tyrosine, you have tyrosine hydroxylase that converts it to L-DOPA, L-DOPA through DOPA decarboxylase converts it to dopamine, and dopamine gets sequestered in these vesicles and gets released under proper stimulation. Now, because dopamine is the missing transmitter, you can obviously give L-DOPA, and this is really the gold standard in Parkinson treatment, giving L-DOPA. Now, once the dopamine is released, it can act on the postsynaptic receptors, which is really what you want to happen. When it is in the synapse, it can be degraded by two enzymes. One is catechol-O-methyltransferase, and the other is monoamine oxidase. So if you wanted to increase the level of dopamine in synapse, in addition to giving L-DOPA, you can block the activity of either of these two enzymes. And that is also something that is used in practice. Now, in addition to this enzymatic degradation, dopamine gets picked up by dopamine transporter back to the cell. And this discovery actually resulted in a couple of Nobel Prizes. And Dr. Raoul is the expert in this dopamine transporter. So if you have any question, you can ask him about that. But as far as the treatment is concerned, therefore, you have L-DOPA. You can give also actually dopamine receptor agonist, something that acts like dopamine and can act on this receptor. So, and we have a couple of these agents, pramipixole, ropinirole, or you can, as I mentioned, inhibit the enzymes. I have a couple of the drugs against for COMT as well, and you can give a combination of these as well. Now, most important thing in all this pharmacotherapy is that you are only getting symptomatic relief, meaning that you are not affecting the degeneration that is going on. So really what we need in this issue is something to stop the degenerative process. Although these therapies give you 5-6 years of perfect function, the problem is that after a few years, L-DOPA can produce what we call L-DOPA-induced dyskinesia, involuntary movement, that sometimes can be worse than the symptoms of Parkinson itself. So that is an issue that is also under consideration. And I'll show you one last slide in that for that L-DOPA-induced dyskinesia. You also have non-pharmacological intervention, the magnetic transcranial magnetic stimulation, which is non-invasive, but you can also have, in some special cases, deep brain stimulation, which is invasive, of course, and is reserved for a few cases. And you also now have under investigation stem cell grafts or autologous transplant or viral gene therapy. These are under development. Hopefully, they will result in fruitful outcomes. Now, in search of novel therapies, and this is where I'm going to be emphasizing, you know, basically that we are a combination of our gene and environment. So the interaction between these two define every person. And we know that there are certain genes that are involved in Parkinsonism, this alpha-synuclein gene, the Parkins, etc. But these constitute only about 10% of the cases. So the majority is what is referred to as idiopathic, meaning that we do not know the cause. But in addition to this genetic, we know environmental factors can have an influence, like farmers that use pesticides or insecticides like rotenone, or the drug or the chemicals to kill weeds, herbicides like paraquat, heavy metals, iron, manganese. MPTP has a very interesting story. In 1980s, I believe, some young people were trying to develop some opiate analgesic compounds for use in their own home laboratory, and they synthesized MPTP and they start using it. And then all of a sudden you were seeing a lot of people coming to emergency room with Parkinson-like symptoms. And this was because they were abusing this MPTP to get high, of course, but this now has become a standard model for Parkinson's disease, because basically when you inject it into animals, it produces most of the symptoms of Parkinson's. Salcinol is an endogenous compound that is produced from the condensation of dopamine and aldehyde. And some patients have higher level of salcinol, which is selectively toxic to dopaminergic cells. Now, as I mentioned before, the biggest risk factor is aging. So aging is hazardous to your health. I'm sorry to say that. And I can feel it myself now, you know, like you got to be careful with whatever you do. Nonetheless, the search is for finding some treatment that can stop the progression of the disease. In terms of the molecular events, we know that you can have misfolded proteins, you can have mitochondrial damage, which can lead to oxidative stress. Mitochondria, as you know, is the energy producing engine of the cell, and this can be the key to a lot of other issues that can lead to oxidative stress, to inflammation, immune dysregulation, apoptosis, excitotoxicity. That's where you get excess release of the excitatory transmitter glutamate that can result in calcium dysregulation, autophagy, dysbiosis. Dysbiosis is now a new field where you have the interaction of the gut-brain axis, and the microbiota in gut apparently can influence a lot of our function, including the brain function and behavior, etc. So this is becoming a new field of gut-brain axis. So dysbiosis means dysregulation in the gut microbiota environment. So knowing all this, I'm gonna basically, well, we have undergoing studies to look at these effects specifically. Now, in terms of the oxidative stress and gene mitochondrial interaction, this is just for your info to say that this might be the key to the problem in a way. And so in search of novel neuroprotectants, I wanna emphasize one very important point: serendipity. Serendipity means by chance, by chance. You know, a lot of pharmacological discoveries are by chance. It's like being in the right time, right place, opposite of being at the wrong time at the wrong place. But with serendipity, the chance, you need to be aware and catch it, okay? So you can't just lay back, say, okay, it might come to me. No, you have to wait for it to come, but then you have to catch it. So that's the catch, to catch the opportunity. So in terms of serendipity, this is how I got involved in my search for novel neuroprotectants in Parkinson. So I'm gonna talk a lot about nicotine because this has been what I've been working on past 30 years. And the way I got into nicotine was when I was a young assistant professor. I had started my lab, and a student came to me and said, I want to work with you. What are you working on? I said, look, I'm working on stress and aging on the hypothesis that stress can accelerate the aging process. And we have to stress the rats, look at their brain. Says, this is really might be too stressful for me. Do you have anything else? I said, look, this morning I was in the library, I was reading, and I noticed an article saying that mothers that smoke during pregnancy have a higher incidence of children with attention deficit hyperactivity disorder, or ADHD. So I said, look, we can get some pregnant rats, give them nicotine, look at their offspring, and see what happens to their brain. And at that time, we did that. We got a paper in 1994 with prenatal nicotine causing dopamine decrease in striatum as well as the receptor. Then, you know, when you get into one area, you start reading and getting more about the importance of that compound and its implication. So the more I read about nicotine, the more fascinating it became. It is derived from these beautiful flowers, and you know it's the constituent of tobacco, which is what people smoke tobacco. They smoke because it gives them some euphoric effect. It's a stimulant like amphetamine. And as you know, it's highly addictive. It's very difficult to quit smoking. But in addition to that, we know that it also has an anxiolytic effect, antidepressant effect, antipsychotic effect. In fact, if you look at the schizophrenic patients, 90% of them are non-stop smokers. And we believe that this smoking is some sort of self-medication with nicotine. And we have done work in all of these, including the cognitive enhancement effect of nicotine, which might have an application in Alzheimer's. In addition to Parkinson, it has analgesic effect, can remove pain. In fact, one compound, epibadidine, that acts on nicotinic receptors can have 1,000 times more potency than opiates. However, because of side effects, it cannot be used. So there is a lot of literature on that as well. And this is where I want to give my emphasis in its neuroprotector effect or neuroprotection. But in addition to this, it can be used, even though it might lead to ADHD if it's used prenatally, it might actually be a form of treatment of ADHD. As you know, ADHD is being treated with amphetamines, so stimulants. So this would be another stimulant that could work. Tourette syndrome, the same. Obsessive compulsive disorder, same. So, and these three comorbid or coexist. So there is literature, and we have done work on all of these basically, and showing the protective effects of nicotine in all these. Now, just a few slides on the mechanism of action of nicotine. You know, you have compounds that are G protein coupled receptors. These are usually metabotropic receptors, but you have, on the other hand, inotropic receptors, where you bind the ligand and you get direct flow of the ions into the cell, or expelling some of the ions out of the cell. And this is very fast acting compared to the G protein coupled receptors, because there you go through second messenger, cyclic AMP, etc. Nicotinic receptors are in very strategic locations in the brain, especially with that mesolimbic system where it has addictive properties, etc. But I want to emphasize the role in PD, Parkinson's disease. And the reason this really caught the attention was that every literature that you look at has found an inverse relationship between Parkinson and nicotine intake. Even cigarette smoking, or any which way you might be getting the nicotine through other compounds, etc. Now, so you say, Yousef, smoking is protecting PD. We should go get a pack of cigarettes right now. I would say absolutely not, because the harm of that tobacco, the 500 or 5,000 elements in there, can kill you before you get to the age where you can benefit from this. So please don't take that as an approach. However, nicotine by itself can be protective, and this is where pure nicotine that is available might be of therapeutic use. And this has been shown in many cellular and in vivo experiments that nicotine does protect against dopaminergic damage. Okay? So for this reason, we are saying that nicotine has anti-inflammatory effect. It also has antioxidant effect. It can suppress the activity of microglia, which can lead to neuroinflammation. And remember, neuroinflammation is induced by microglia. Microglia have many important functions, but when it becomes excess, then you have neuroinflammation that can cause damage by producing some proteins, and including alpha-synuclein that is of relevant to Parkinson. So you basically want to stop this neuroinflammation, and nicotine does that. I'll give you some other examples. So basically, in terms of the mechanism of action, it can inhibit microglial activation, suppress inflammation. It can also increase BDNF, brain-derived neurotrophic factor, which is very important in synaptic plasticity and has a very important role in depression, which, by the way, as I mentioned, coexists with Parkinson's. So if nicotine can affect BDNF and can have this inflammatory suppression, so it might have a double protection in terms of dealing with degeneration as well as non-motor symptoms in PD like depression. And it also has, as I mentioned, antioxidant effects. So with all these, we are awaiting clinical trials of nicotine in Parkinson's disease. Actually, for your info, they have tried nicotine patch with Parkinson, but I could have told them this would not work, the patch, because patch gives you a steady state of nicotine. It's good for smoking cessation, but not for PD. For PD, you need a pulsatile stimulation of the nicotine receptors, just like how the smokers smoke, they don't have steady state levels. So this, I have two papers in that. One I have mentioned here. You can look for a lot more details in those, basically. Now, The next compound I want to try, so please give me a hint about the time so I don't go too much over. The other compound is butyrate, and this also was serendipity. The way we got into butyrate was we were looking for novel antidepressants, and you might all have heard that this drug, ketamine, is now, at least in US, is approved for very severe and non-responsive depressive patients. And it is very good to intervene in suicide cases because it is a very fast-acting antidepressant. And we were looking at, let me go on slide 4. We're looking at the ketamine antidepressant, and then one of our colleagues said, look, there is this gut-brain interaction. Why can't we look at the ketamine effect on microbiota? So yeah, we have the animals, we can get the gut, get the microbes, look at them. And we did that, and we found that butyrate, or microbes that are involved with butyrate synthesis, are very heavily implicated in ketamine effect. So said, okay, the same like with nicotine, you go and look at what butyrate is and what it does. We know butyrate is a short chain fatty acid that is produced in gut microbiota and is very important in maintaining the integrity of the large intestine, and is heavily involved in gut-brain axis. And this led us to more research on butyrate, and said that, wow, this has also, like nicotine, antioxidant, anti-inflammatory effect, and many other good effects as well. And actually we saw that butyrate might have similar things. Would it be having neuroprotective effects as well if it has all the characteristics of nicotine? And we did some experiments with nicotine against salsidinol that I mentioned, and we found that yes, it indeed has protection against this, and we published this paper. Let me see, this was last year, and then we went into more understanding of the mechanisms. And so, as I mentioned, we can impede or reduce the progression of Parkinson by affecting the gut microbiota. And butyrate is involved in some connection with alpha-synuclein, dysbiosis. And basically what we are saying, make a long story short, is that because of the protective effect of sodium butyrate against dopaminergic cells, it might be a good candidate for Parkinson as well. And this would lead to the mechanisms, how it does it. It has a lot of different molecular effects, including mitochondrial protection. And also it has some epigenetic effects in that it affects the HDAC, it inhibits the HDAC, the epigenetic mechanism. So in short, butyrate has beneficial effects that in various models of PD. And again, just like nicotine, we are waiting clinical trials. And actually there are models showing that it is effective. Problem with butyrate, and I'll show you a couple of other compounds, might be that it is not readily available, like in terms of bioavailability and getting enough to the brain. So the other possibility would be the combination therapy of butyrate and nicotine, and two other plant derivatives that I would like to mention very briefly in the same categories. One is resveratrol, that has all the same effects as nicotine and butyrate: antioxidant, anti-inflammatory, neuroprotectant, antidepressant. And the other one is curcumin that is derived from the turmeric plant. This also has antioxidant, anti-inflammatory, neuroprotection, antidepressant. The problem with these two compounds, curcumin and resveratrol, is mainly the bioavailability, having enough to get to the brain. And so now there are a lot of studies trying to get to some nanoparticles that can reach the brain to get the beneficial effect. So these two and butyrate bioavailability is a critical question. I promised one slide on L-DOPA-induced dyskinesia, and we just published this chapter in Handbook of Neurotoxicity, which says 3 compounds, nicotine included, can be used for dopamine-induced dyskinesia. A lot of nice work showing that this might be the case. Ketamine that I mentioned would probably have the same effect, and cannabinoids, that is a large area of research at the moment. Amantadine is actually a weak NMDA receptor antagonist, whereas ketamine is a stronger antagonist. So both might have the same mechanism. Amantadine is actually an antiviral also, but nonetheless, you have these compounds that can open the line in future research. So I conclude by 2 things. One, saying that the field is wide open for bright young minds like yours, and the other, that you cannot do this alone. You need collaborators inside the institute, outside. During my career, I have collaborated with a number of labs, and this is only a partial list in the United States, in other countries, Hungary, Czech Republic, Chile, Spain, Mexico, Brazil, and I hope to add Russia to this list sooner or later, and the fundings. So this is my talk, and I thank you again all for your attention.
Thanks a lot. Thanks a lot for this beautiful.
Yousef, great. Thanks a lot for your great talk. Very interesting and very encouraging. So there are some drugs finally may appear, yeah?
Yes, that's actually, you know, we are, somebody raised that. I'll get. So this nicotine trial, right? Mm-hmm. We actually started applying for a patent for using nicotine inhalant, you know, because it's available. Mm-hmm. And I have been trying my darnest to find some clinicians to try it, but clinical trials are really very difficult. So maybe that's what we can talk, Raul, and you can get someone to do it. I don't know if nicotine inhalants are available in Russia, but that might be really something we can work on.
Okay, thank you for good idea. Yeah, let's think about that. Yeah.
Right.
So it's inhalants or intranasal?
Both. There is the problem with nasal spray is that it can be a little irritant to the nose, and that's why actually, you know, some colleagues in Mexico tried that, and there was very small number of samples. Unfortunately, couldn't continue, but there was some really positive results. You know, I'm just dying to get that tried, you know, in a clinical setting. Mm. I think it would be. There are anecdotal evidence in YouTube, but not people using nicotine inhaler for dyskinesia specifically. But we say both Parkinson as well as dyskinesia. So there is a lot of potential, I believe. So I see 2 hands raised. One is...
yeah, I think we'll have short questions because we're a bit out of time, but I'll turn on the microphone. Saveli?
Thank you, Yousef, for a good lecture.
My pleasure.
I have maybe 2 questions. First about oxybate.
stress.
You say that it can have neuroprotective and anti-inflammatory functions, but what's about modulation of dopamine neurons through GABA B or GHB receptors? What do you think about that?
You know, that's interesting question. The in pharmacology, I have come to believe that nothing is exactly what you think it is, that there is always other possibilities that, you know, like, for example, ketamine is NMDA antagonist, but might act with nicotinic receptors. And I believe vice versa. And especially with inotropic receptors, there is very good chance. So the inotropic receptors of GABA system could be a target for nicotine as well. But I don't think much has been done in that. It's possible, definitely, yes.
Yes, thank you. And next question about nicotine agonists. I think we need to stimulate pharmaceutical industry, for example, as new forms of nicotine or maybe a new nicotine agonist, because nicotine is well-known molecule and there's nothing to patent. So maybe another nicotine agonist can be maybe pharmaceutical industry have a bigger interest in new nicotine agonists than in nicotine per se.
Absolutely. I think you hit the nail on the head by the profit making of possibility. You know, like if there is something already available, you can give it easily to other people, but doesn't make money, maybe it's not so attractive. But in regard to your suggestion of nicotine modulators, nicotine agonists, we are actually, as we speak, looking at two compounds that are nicotine modulators. You know, like they can boost the action of nicotine by themselves, might have this protective effect. So those are possibility. But again, you know, we are doing research at the basic level, and to bring it to the pharmaceutical, unless there is some internal interest that they can develop, it's very difficult to break through that cycle. Yeah, I'm hoping, you know, that what we do in basic, they would take it and go with it. And so, and not only in Parkinson, but also, like I mentioned, in depression, schizophrenia, and others as well. So it's a wide open field, really.
Yeah. So Pfizer have got Champix, and maybe Champix can have a chance to.
No, Chantix was used, but Chantix is a weak alpha 4 beta 2 partial agonist, and it only seems to be working really for smoking cessation, not perfectly, but better than placebo. Really, nicotinic agonists, more selective, would probably be the way to go.
Yeah, thanks a lot.
Sure.
We are a bit.
One more question we can get from Ramilia.
Okay. Yeah. If you could make it short, just a minute.
Okay. Thank you very much. You mentioned that nicotine must be administered periodically instead of constant concentration. Why is it so? Because
when you have with the nicotinic receptor dynamic, when you have a steady state of nicotinic presence, you downregulate the receptor, and you need to bring those receptors back to steady state so you can hit them again. So when you are keeping them under constant downregulation, there is no way of re-stimulating them again. So the way people smoke, they get the pulsatile, the stimulation of the receptors, then they wait another 10 minutes. Those receptors might have been desensitized, but then they come back and they hit them again and they get the high. And actually the smokers in the morning, the first cigarette is what they get the best effect because they have been deprived, you know. So that's the reason, basically.
Okay,
but just to finish, if there is any question, whatnot, I had my email in there. I would be more than happy to correspond with anyone, answer any questions. And of course, with Raul, we have to come up with some joint project.
Yeah, Yousef, let's think about that. It's very interesting. Yeah.
Thanks a lot. Yeah, thanks a lot. Yeah, also there is one question in the chat. So if you could read it and probably answer it in the chat, that would be nice.
In my laboratory, we participate transplanting the gut microbiome of a healthy person to another. Can this prevent or reduce the manifestation? I think it is the application of gut microbiota, and there is a lot of good literature on in animal studies actually getting the microbes from the environment, the gut, and transplanting it into another. Yes, this is absolutely a great area. I think it would open a lot, and butyrate fits very well in that. So yes, that's definitely a possibility.
Okay, thanks a lot. Thanks a lot for joining us.
Thank you.
Thank you. Thank you very much.
I'll stand around.